Hi, everyone. Welcome to the SSR Resident Education Club webinar. I'm Martin Toriani from Harvard Medical School and Massachusetts General Hospital in Boston, and I'll be the moderator for this lecture. I'm thrilled to introduce our speaker today. He's Matthew Lee, a tenure-track assistant professor of radiology at the University of Alberta and musculoskeletal radiologist in Edmonton, Alberta, Canada. And Matt was chief radiology resident at MGH, and last year he was one of our clinical fellow in our MGH MSK radiology program. Matt, importantly regarding this talk, Matt is an incoming associate editor of Radiology Artificial Intelligence, and he's a regular peer reviewer for several radiology journals, including Radiology, Radiology AI, Skeletal Radiology, Academic Radiology. And he will generally focus on submissions that are regarding artificial intelligence in MSK radiology. So I'd like to welcome Matt, and Matt, take it away.
Thanks, Dr. Toriani, for the kind introduction. Well, tonight, I'd like to introduce a clinically oriented approach for critically reading AI research for the musculoskeletal radiologist. As everyone on this webinar is well aware, over the past few years, AI has kind of become a pervasive topic of research and discussion within the radiology community. As you can see, in 2022, with the year not yet over, around 1,100 articles have been published and indexed in PubMed related to AI and musculoskeletal imaging. Growth in the literature volume appears exponential. The US FDA has a database of AI or machine learning enabled medical devices. AI tools are regulated as medical devices by the FDA, and there are 392 FDA cleared products in radiology. Nearly 100 of these were cleared in 2022 alone. So clearly, AI is here to stay. It's not just a fad. This is a picture from RSNA from this year, and you can see tons of people crowding the RSNA AI theater. And so I think it's becoming increasingly important that radiology residents and radiologists in general learn to critically read AI literature. But that's not something that you typically get training for during your radiology residency. And the challenge is that most of us don't have a background in AI or machine learning. We're trained to interpret images and do image guide procedures, and we try to do the best we can with that. But AI is something that we don't really receive training in. Unfortunately, the first thing that people often talk about when they talk about AI are neural networks, kind of the fundamental type of algorithm that has kind of revolutionized machine learning in the past few years. And so you might open up an AI-related paper and you kind of feel attacked by all the linear algebra. And this is just an image from Andrew Ng, who's a famous AI person's course on YouTube. The radiology AI literature can be overwhelming and sometimes indecipherable for the clinical radiologist. So what do? Much like you don't need to be an expert in MRI physics to appreciate articles on MRI applications, you don't need to be an expert in neural networks to appreciate articles studying AI applications in radiology, though it can still be quite difficult. The radiology community, recognizing these challenges, has done a lot of great work to create guidelines to help authors, reviewers, and readers to understand and appreciate these articles. These examples of articles from radiology in the past few years and radiology AI offer some useful guidelines and foundational works, which you can use as guidelines. And I do highly recommend reading them if you're interested in the topic, but they can be daunting. For example, the checklist for artificial intelligence in medical imaging, or the CLAIM guideline, has, it's a 42-point checklist. And most of us, when we just want to, cursorily look at an article, we don't want to have to go through these checklists. So sometimes you can find yourself, when you open an AI article, wandering among the trees and you kind of lose sight of the forest. And so my objective during this webinar is to give you, the radiology resident, a practical approach for critically reading AI research focused on specifically clinical relevance. We're not going to go into the math. We're not going to go into all the kind of different network architectures and all those kinds of details. But we're going to focus on how you can evaluate the evidence and try to make your own judgment about the AI literature, particularly as you can see, there's been so much growth in that literature in the past few years. I'm going to use cases of AI applications in the musculoskeletal imaging literature in particular to illustrate those points. Specifically, today we're going to focus on interpretive AI tasks, like diagnosis and prediction for medical images, as opposed to non-interpretive tasks like accelerated MRI sequences or hanging protocol automation, although many of the same principles do apply when reading about interpretive and non-interpretive applications. So let's get started. So my approach to reading an AI paper in radiology can be broken down into 5 key questions. 1, what is the task being performed by the AI? 2, what is the claim being made? 3, how strong is the evidence supporting that claim? 4, is the level of performance good enough to have potential clinical impact? And 5, if deployed, how may the AI affect the clinical workflow? So let's dig a little bit more into these questions. So the first question I like to ask is, what is the task being performed by the AI? So for interpretive AI tasks, you can divide this into 3 main categories. The first is diagnostic classification. The second is segmentation or localization. And the third is prediction. When it comes to diagnostic classification tasks, you can further subdivide these into binary, categorical multiclass, ordinal multiclass, and continuous classification tasks. So to give you an example, a common example of a binary classification task would be the question of fracture versus no fracture. And many AI models have been trained to address this particular question. And in this example, you can hear an image of a hip fracture on the left side from a hip fracture detection AI paper published in 2020, which showed an AI model that could pretty accurately detect these kinds of fractures. An example of a categorical multiclass classification that can be performed by AI is also found in that same paper from 2020, in which they actually classified hip fractures into different types, including non-displaced femoral neck fractures, displaced femoral neck fractures, and intertrochanteric fractures, among other classifications. So you can see the difference between a binary and a categorical multiclass classification. In some cases, you can also have ordinal multiclass classifications. So in contrast with categorical multiclass classification, an ordinal multiclass classification involves multiple classes that can be ranked. So for example, AI systems have been trained to automate the Kellgren-Lawrence grading system for knee osteoarthritis severity. The Kellgren-Lawrence grading system ranges from 0 to 4, where higher grades indicate greater severity of osteoarthritis. And so you can see how this is different from a categorical type of class. An example, and lastly, some tasks also involve AI outputting a continuous scale, which is not technically a type of classification, rather it's a regression problem. But for example, a pediatric bone age AI model can output an estimated bone age from hand radiographs. So those are the main kinds of diagnostic classification tests that you're going to see in AI. You'll also see, besides that, you'll also see a lot of segmentation and localization, which essentially means the AI can identify where in an image something is of interest. You can divide that segmentation and localization task into 2 broad categories. First, whether or not it's localizing an anatomic structure or an abnormality of interest. So to give you an example of an anatomic structure, there are a lot of AI models that have been published in the musculoskeletal imaging literature to segment cartilage from knee MRIs, which is an important step in work involving T2 cartilage mapping as kind of a pre-processing step. Alternatively, AI models can be trained just to draw bounding boxes, which is kind of really a fancy word for a rectangle around a abnormality of interest. So going back to that hip fracture paper from 2020, that research group also showed how their AI model could not just do the classification, but could also localize the abnormality of interest. And third, the third task that is often performed by AI may be prediction. And so you can divide prediction in the common tasks into these 3 categories, including opportunistic screening, clinical outcomes, and pathology. So to give you an example of an opportunistic screening task, I'm referring to diagnoses that aren't typically made by the imaging modality being analyzed by the AI. For example, as radiologists, we often look at lumbar spine radiographs, but we as humans don't diagnose osteoporosis based on the radiograph routinely. So AI tools like the example from this paper have been developed to try to automate this process, which is a growing area of research in opportunistic screening and radiology studies. Clinical outcomes can also be predicted. So for example, in this recently published work from Radiology AI, An AI model could take a preoperative hip radiograph and other surgical and clinical variables as inputs and predict total hip arthroplasty dislocation within 5 years. And the idea here is that that could help inform and guide the orthopedist when planning their surgery. And lastly, AI can predict pathology. In this example from 2021, an AI model from the literature could predict whether or not a bone lesion was benign or malignant based on the input MRI. So as you can probably see by now, there are a lot of different interpretive tasks that AI can perform, particularly in the musculoskeletal imaging literature. Many papers will include a combination of multiple tasks, but before moving forward in your critique of any AI paper, when you're reading a paper, just make sure you understand what the AI is supposed to be doing. That's really, sometimes there's going to be a lot of complicated terminology being used, but if you can just kind of boil down what they're trying to do, that's going to help guide your critique of the paper. The second question I like to ask is what claims are being made? So, once you've figured out what the AI is supposed to be doing, you can ask this question. So in the interpretive radiology AI literature, there are 3 common claims regarding some tasks that the AI is trained to perform. So first, AI has a high level of performance on a task. What is high? That's another question and is often arbitrary. And there's some nuance interpreting such a finding, and we'll come back to that later. Second, AI has radiologist level or better performance on a task. And third, radiologists using AI perform better than without AI on a task. And some papers will contain more than one of these claims. So once you've figured out what the claim is, what the AI is supposed to do, and what the claim is, the next and probably the most important question is, how strong is the evidence supporting these claims? And you might first go to the materials and methods, and you look at the results, and you're going to see these pictures of schematics of neural network architectures or other kinds of AI models, and you might be overwhelmed. But unless you have a background in AI and machine learning or curious about it, I would actually consider just skipping this and focusing on how the AI model performance was tested. From a practical point of view, for most readers, you don't need to understand the AI and its inner workings, but you do need to understand how it was tested. So don't get bogged down in the details. So we can assess the strength of the evidence depending on the claims. So with respect to the question, or the point that AI has a high performance on a task, which almost all published work does. So, they will all say, oh, this AI has extremely high accuracy, is a high area under the receiver operator characteristic curve. The AI has high sensitivity or specificity, high F1 score. And, there are all these different kinds of metrics that are being used. And, if it's published, it's probably reporting a pretty high performance. So I like to ask a few questions about, how this performance was determined. And so the first sub-question I have, and perhaps the easiest to discern, is whether or not external testing data was used. The training data and testing data should not overlap at all. Ideally, the testing data should be from a different institution from what was used to train the AI model. Even better, testing data could be from multiple external institutions from diverse and heterogeneous backgrounds. And why is this important? Well, generalizability. And so this is a concept where AI models may perform well when tested on data that is similar to what it was trained on. However, once you give it new data from an external source, the model performance often deteriorates. So Zek and colleagues back in 2018 published this seminal work looking at pneumonia detection on chest x-rays across different institutions or data sets, and kind of showed how these deep learning models used in radiology, artificial intelligence applications, did not show generalizability in many cases. And so while most of the leading journals publishing AI articles in radiology generally require some form of external testing right now, there are still articles being published without separate testing data. And as you know, there are a lot of different journals out there, and not all of them have as rigorous editorial standards for publishing AI research. So the second sub-question, once I've confirmed the presence of external testing data, is I like to look into how patients or cases were selected for the study. So let's look at an illustrative case for why that's so important. So this is a recently published article in 2022 titled Differentiation Between Subchondral Insufficiency Fractures and Advanced Osteoarthritis of the Knee Using Transfer Learning and an Ensemble of Convolutional Neural Networks. And so the authors in this paper described an AI model to differentiate between these two pathologies. And the premise of the proposed AI use case is that both subchondral insufficiency fractures and advanced edema on MRI. And so here's kind of a screenshot of the abstract. And in the article, the authors claimed that the AI model was highly accurate in differentiating between subchondral insufficiency fractures and osteoarthritis, achieving higher or equal performance to MSK radiologists. And on the surface, this sounds interesting, but let's dig a bit deeper into how patients were selected for this study. So if you look into the materials and methods section, we can find here that cases where subchondral insufficiency fracture and osteoarthritis coexisted were actually excluded from inclusion in the study. And so why is this exclusion criteria clinically relevant to the interpretation of these results? Remember, we're thinking about the clinical, you have to put on your doctor, your radiologist hat here and think of the clinical relevance. Well, it's important because subchondral insufficiency fractures are associated with osteoarthritis. And so, for example, in this relatively recent retrospective study, about 67% of patients with subchondral insufficiency fractures of the knee on MRI had KL grade 3 or 4, so Kellgren-Lawrence grade 3 or 4, so essentially moderate or severe osteoarthritis. And so clearly, and as you would, for the residents who are more senior in their training, it's a pretty clear association between osteoarthritis and risk of subchondral insufficiency fractures. And so as a result, the exclusion of knee MRI cases in this paper that had both subchondral insufficiency fractures and osteoarthritis substantially changes the interpretations of these results, because the AI model might be training, that was being trained, might be learning to differentiate between knee MRIs without osteoarthritis and with osteoarthritis, rather than differentiating between subchondral insufficiency fractures and advanced OA associated with bone marrow lesions. So as the AI model is not trained on the cases that have both osteoarthritis and subchondral insufficiency fractures, the model would likely fail in a clinical setting, because that's what you'd expect in the real world. So as this illustrative case demonstrates, understanding how imaging studies are included, so how the patients or cases are selected for the testing data or the training data, can be critical for evaluating the performance of an AI. So you can imagine the next time you see a paper, right, and they have high performance, make sure you think twice about this particular factor. The third sub-question I like to ask is, how was the pathology or abnormality defined in the study, as this can also affect the interpretation. So to give you a hypothetical example, for example, let's say you had an AI model that was trained to differentiate between rheumatoid arthritis and normal hand radiographs, and a very high performance was reported. However, let's say in this hypothetical example, in the training and test data, all of the rheumatoid arthritis cases showed advanced manifestations of rheumatoid arthritis, like extensive erosions and joint subluxations, like in the image on the left side of the screen. Excuse me. If you were to show that AI model a subtle case of rheumatoid arthritis, it would likely not detect the abnormality. But as you know, as a clinician, as a radiologist, detecting RA early is what matters clinically to allow the initiation of treatment. Once you have advanced findings, it's too late to start that treatment. Thus, so how the pathology is defined is important to recognize. The fourth sub-question I like to look at is, how was the ground truth or reference standard determined for the data used in training and testing? So in radiology AI articles, this typically involves radiology reports or expert annotations of imaging studies. And the evaluation of performance can be affected by how this ground truth was determined. So let's look at another kind of illustrative case from the literature. So this was a paper from Radiology Artificial Intelligence published back in 2021 that looked at AI for scaphoid fracture detection. And overall, this is a rigorous, high-quality paper. And the purpose of the study was to develop and compare an AI's performance to 11 radiologists on radiographs. And they made the claim that their convolutional neural network, or their type of AI, achieved radiologist-level performance for this task, as supported by the lack of a significant difference in the area under the curve, a measure of the ability of the model to discriminate between fracture and no fracture, between the radiologist and AI. And so overall, this study was well done. It checked off the 42 boxes from the claim criteria and was overall well written. But there are some nuances in the interpretation of these results, which I'd like to highlight. So if you go to the method sections of the paper, you'll find that's for data sets 2 and 3. And importantly, data set 2 is the data set that was used to train the scaphoid fracture detection AI. The original radiology reports are used as ground truth or reference standard labels for fracture or no fracture. So the AI is essentially being trained to emulate the radiologist's performance. It can be no better than a radiologist, which means that the AI will not be able to detect radiographically occult scaphoid fractures. So why is that important? Well, as you know, as radiologists, scaphoid fractures are often radiographically occult. And in a retrospective study from 2015 using CT as a ground truth, one research group found that X-rays have a sensitivity of 66% only for scaphoid fractures. So if the scaphoid fracture AI model with radiologist level performance was deployed, we would still be missing these radiographically occult fractures. But the thing is, these are the cases where the missing these cases with the missing fracture where they are subtle or they're radiographically occult. Those are the ones that are going to be clinically impactful if they're missed. Around the same time as the publication of that other paper, another research group also reported on the training and development of an AI model that could detect radiographically occult scaphoid fractures specifically, where they used follow-up radiograph CTs and MRIs as ground truth for occult fractures, including the data set for training their AI with high performance. And in this AI, they focused on detecting radiographically occult scaphoid fractures specifically, which really addresses a more clinically significant question. And so what you can see here is that both of these AI research articles are well written. They're both high quality studies, and the authors for both groups should be commended for their rigorous work. And even the title of the articles are very similar. But as you know, the difference in the ground truth here completely changes the clinical significance of the findings and the functionality or real world usefulness of the AI. All right. So the fifth and last kind of sub-question I like to ask is about how the test data is representative of the intended use case. So ideally, the test data is representative across multiple demographic dimensions like age, sex, race, geographic location, as these factors can affect the performance of a model. And so there's a lot of literature studying bias in AI, particularly now. It's become an increasingly popular topic of research. But just to give you an example for recent work published in Radiology, a pediatric bone age AI model was found to generalize well to an external test set. However, they still found significant differences in performance of the bone age AI related to sex, age, and sexual maturity differences. And this is an example of work that highlights the issue of bias. And so always keep that kind of in the back of your mind when you're interpreting an AI study and looking at the kinds of populations that are being trained and tested on. All right, so those are the 5 sub-questions that I find useful to ask when assessing the performance of an AI model. So for the second common claim, that AI has radiologist level or better performance on a task, the same questions really should be asked as for claim 1, but with the added caveat that the comparison would be with radiologists on a task that simulates the real world environment. So make sure it's something that actually a radiologist would do in the real world as opposed to a completely artificial environment. Regarding the third claim that radiologists using AI perform better than without AI on a task, there are many different study designs for assessing the difference in performance of radiologists without and with AI assistance. And I'm not going to go into the detail here of all the different study designs. If you're interested, I would refer you to a recent review paper that was published in Radiology by Park and colleagues this year that kind of reviews these different study formats. But typically, the most common study designs that I've seen in the literature, the first would be the sequential format. So you have a group of radiologists, a few radiologists, they'll interpret studies without AI. And then there will be a washout period. So you kind of wait, 4 weeks, a couple months, and those same radiologists will interpret the same studies, except with AI assistance, and then kind of look at the difference in performance. The other type of study, which is really the gold standard, would be a randomized clinical trial, where you'd randomize one group of radiologists to use AI and one without and see and look at the outcomes. And importantly, what the outcomes are is also a very nuanced point. But regardless of what the study design is, I want to know if the AI assistance matters in any meaningful way, which leads us to our next main question. So let's say the AI works great. We have great performance, but is the level of performance good enough to have potential clinical impact? And so I'm not just talking about statistical significance here. I'm talking about, does it actually, do you think as a clinician, as a radiologist, that this could actually impact the care of a patient? And that's kind of a recurring theme that I just want to emphasize, in that what we care about when reading the paper is, is this actually going to make a difference? And so kind of to highlight the nuance in those kinds of analyses, I'd like to kind of go through another illustrative example. And this is from a seminal article from 2018. So this is one of the first published papers looking at AI on knee MRI. And so it's overall, a high quality paper. They did a user study where they compared performance of their AI model with multiple radiologists and orthopedic surgeons, and looked at performance with and without the use of AI. And they specifically looked at ACL and meniscal tears. And so this was a big paper. And overall, the paper's conclusions stand. But within the discussion, they do talk about the possible clinical utility of the model assistance. And so they write in a passage, when clinical experts were provided model assistance, there was a statistically significant increase in the clinical expert specificity in identifying ACL tears. And so there was an improvement of 4.8%. And they further make the claim that in the validation set containing 62 exams negative for ACL tears, the increase in this specificity would mean potentially 3 fewer patients sent to surgery for suspected ACL tear unnecessarily. And at face value, just reading this might sound reasonable, and the media might think this sounds reasonable as well. But remember, the decision whether or not to operate is a clinical one and relates to the patient's knee stability on exam and other clinical factors. So a 4.8% increase in specificity means the radiologist using AI would have fewer overcalls of ACL tears, in other words, false positives. However, the false positives likely represent partial tears as opposed to complete tears, which most radiologists don't have a problem diagnosing. So with partial tears, many patients end up with non-operative management anyways. So would this 4.8% increase in specificity have any significant clinical impact? So that doesn't seem so clear. And so as this case demonstrates, you should always consider the level of performance with respect to the clinical significance and how it fits into an actual clinical workflow and the management of a patient. And that'll help you kind of put the results in a real world context. And so the last main question that I like to ask is, if deployed, how will an AI affect the clinical workflow? And that might be for the radiologist. It might be for the ER docs. It might be for the orthopedists. A lot of potential AI applications currently being explored may never find traction in clinical practice because they do not make the life of a radiologist or other clinician easier or faster. And so this is a question that will come up increasingly in the coming years as AI tools gain maturity. But the future is bright. In this recent paper, that looked at an AI model's application for detection of fractures, they actually found a improvement in sensitivity and a possible improvement in specificity of fracture detection, so a performance improvement by radiologists and non-radiologists without actually lengthening reading time. In fact, there was actually a slight decrease in reading time. And so hopefully we're going to see more of these kinds of papers in the future. And hopefully we're going to see that kind of impact roll out into the actual clinical real world. So, that was a lot of information. We covered a lot of different kinds of applications of AI and kind of the questions that you should ask. But the next time you open up an AI paper, and there are going to be more and more AI papers in the future. So even if you hide under a rock, you're not going to be able to escape. I like to ask these 5 key questions. So, first, again, what is the task being performed by AI? Just know what they're doing. 2, what is the claim being made? And there might be multiple claims. 3, how strong is the evidence supporting that claim? And as we talked about earlier, there are a lot of questions that you can ask about the strength of the evidence. And importantly, the questions that we asked are not about the AI model and the internal workings of the AI model, but really just about how was the test performance evaluated. 4, we want to look at does this level of a performance of AI, is it good enough to have potential clinical impact? And 5, if deployed in a clinical workflow, how is that AI going to have an impact? So thank you so much for your time this evening. I really enjoyed talking to you about this topic. And the next time you read a paper on AI, just think of those questions. I'm happy to take any questions, and feel free to email me if you think of anything else later on.
Thank you, Matt. That was awesome. Thanks so much. If for those who are participating, if you want to shoot some questions over, please do now. Probably I will see them on my little Q&A window. In the meanwhile, Matt, let me ask you something. You have reviewed a lot of AI papers, and now you are taking on a pretty big responsibility of being an associate editor in Radiology AI. And I'm wondering, we probably have a lot of residents watching, and maybe a lot of them are involved in papers that are being submitted to radiology journals that involve AI. So one question that I wanted to ask you is, maybe it's a two-part question, but the first part would be, as a reviewer and now associate editor, what are the most common problems that you see in papers that are submitted that are deal breakers and that lead to rejection right away? Are there any kind of pointers that you can give us that would help preempt serious problems in a submission?
Yeah, that's a great question. Thanks, Martin. So I think the most common problem that I see is that the methods are inadequately documented and detailed. So you'll see a lot of papers where the authors really don't describe their AI methodology at all. It's unclear how the test and training data were partitioned, how the labels and the ground truth are defined. All of these things, you need to make sure that you have adequate documentation within the actual article, so that the findings are reproducible and actually are interpretable in this context. And so I think the number one reason for the variety of journals that I review for, that an article really gets dinged, is that the methods are just inadequate. I think the second common issue that I see, and this is specific to the musculoskeletal imaging AI space, is that often we'll see papers where authors will try to publish kind of some application that doesn't really fit into any clinical workflow. And so it's a situation of a hammer looking for a nail, in which you think, oh, we have AI, so we can do this, and we show that we can do it, but it doesn't really have any potential use case. And a paper doesn't have to be perfect. It's a publication, is just showing some sort of advance, and it doesn't need to show an immediate clinical use case. But I like to see at least a potential. I could imagine if this technology matured a little bit and they kind of refined it more, how it could fit in an actual clinical workflow. And so I think those are probably the two kind of red flags that really lead to probably early rejections of papers. The bulk of most research is done at this time. The AI field has gotten a lot more mature, and that most of the papers that we see now are a little bit better than they were a few years ago, or a couple of years ago, 2-3 years ago. But that said, you just see the same problems over and over again.
Right. And so the segue to that would be then, for those residents that are watching you, and perhaps do you have any words of advice or wisdom, if they would like to be involved with research, or if they are just getting started with research that involves AI, and they're working with obviously more senior, either attendings or residents, fellows, and perhaps what kind of guidance would you give the residents that are starting to get involved with this, so as to, I don't know, regarding choice of projects or perhaps, some other type of interests, how to develop interests in the field?
Yeah, that's also a good question. I think as a resident, the challenge is you're busy with your clinical work, and so often it's hard to find enough time. So realistically, unless you're able to get some protected research time, for those of you in North America, like the RSNA resident research fellow grant, unless you're able to get protected time, it's a little bit hard to work on these kinds of things. But that said, if you do happen to have some free time, there are a lot of open source or kind of free resources out there to gain at least a background, whether on YouTube or through other sites like Coursera. And so I recommend kind of building a basic foundation. You don't have to become an expert, but learn to speak the language of the computer scientists who can talk about the AI in more detail and who you could potentially work with. Of course, if you already have a background in computer science or AI or machine learning, you can kind of jump into it a little bit more easily. But for the majority of radiology residents who do not, it's probably best for you to try to partner with someone who's more, partner with someone who has a more technical background. You can also get involved in kind of the peer review aspect just to get more experience with critically reading this kind of literature. There are radiology training editorial boards for a lot of journals out there, which you can apply to pretty much annually to join essentially a panel of radiology residents or relatively junior trainees to get some experience with peer review, with the editorial process. And so Radiology Artificial Intelligence, the journal, has one of those. Radiology has it, Radiographics has it, the JACR journal has that. And there are probably other radiology related journals that have that. And those are good opportunities for residents to get involved in kind of the critical peer review process.
Awesome. All right, let me see if someone, okay, I don't have any questions from the audience here. So, well, I guess maybe given the hour here on the East Coast, maybe we can wrap this up. Once again, Matt, I want to thank you so much for the talk. Everyone who's watching, keep in mind that there will be another session in January. It's January 18th. That will be regarding hip MRI. So I guess we will resume these sessions next year. I again want to mention to Matt, thank you so much for your talk. It was fantastic. And I want to wish everyone happy holidays, happy New Year, and see you next year.